Faced with a difficult cataract extraction, such as in this case, it is important to do a lot of planning preoperatively. Corneal topography demonstrates that there is 5 diopters of oblique astigmatism. This is something which one will want to address during the surgery if possible. Present a summary of the findings and issues to be addressed. Now we outline various management options open to us to manage this difficult case. The patient presents to theatre initially after delay with now a small pupil. This is immediately a complication which has to be addressed and is done so by using intracameral injection of dilute cyclopentolate and phenylephrine diluted in BSS. The steep corneal meridian is then marked, and then 2 scleral pockets are created to facilitate transscleral suturing in order to allow the utilization of a sutured Keone ring segment aimed at supporting the infranasal aspect of the capsular bag where the zonules are deficient. A further pocket was also created supratemporally in case the superior temporal zonules were also affected. Facilitate the creation of an intrascleral pocket, as demonstrated in this video, it is essential that the eye is held firmly with the non-dominant hand to provide adequate countertraction to facilitate this aspect of the surgery. Making a capsulorhexis, as in this case, it is important to commence the pull of the rhexis utilizing the strong zonules as countertraction. Always use a shearing technique as shown to reduce the forces involved rather than any form of ripping technique which increase the forces. Make the rhexis initially small. It can be enlarged later if required once the tension ring has supported the bag. Phacoemulsification is carried out gently, always utilizing the free hand with the chopper, in addition to simply chopping the soft nucleus, also to guide lens fragments towards the phacotip and away from the weak area of zonules. Carrying out cortex removal, again start where the zonules are strong. Subsequently, only very gently assess what cortex can be safely removed from the area of zonular weakness here, supported only by the iris hooks, prior to implanting the capsular tension ring. As always, the capsular tension ring should be implanted extremely gently. The second instrument should always be at hand to facilitate and help remove and unclip the capsular tension ring from its introducer and ensure that the ring does not catch the anterior capsular edge but rather safely goes below this. The rest of the cortex is now gently removed with the supporting capsular tension ring providing sufficient countertraction to allow cortex removal. To introduce the trailing haptic into the capsular bag, there's principally a downward force is utilized to enable the haptic to enter without introducing further potentially damaging rotational forces. A two-handed approach is then utilised to rotate the toric lens into the appropriate position. This again safeguards the weak capsular bag. The iris hooks are then disengaged from the anterior capsular edge, and the final position of the lens is carefully assessed to ensure that there is not any significant further subluxation away from the known weak area of zonules. In this case, there's still uncertainty whether or not subsequent capsular fibrosis could further affect the final intraocular lens position. Toric intraocular lenses do not work well with displacement, therefore a sutured Keone ring still might have been a better final treatment. However, transscleral sutures are also associated with significant known morbidity, and therefore a decision was made to leave this case as is, but to follow the case closely and potentially again intervene should intraocular lens dislocation occur.